Hello, welcome. I'm Dr. Andrew Peterson, board certified periodontist practicing out of Arcadia, California. Have you ever wondered when you send a patient over for a periodontal referral, what's the conversation that happens between the periodontist and the patient? What treatment options are discussed, and how are those modalities going to treat the patient in the best way possible? Well, tonight I'm going to give you a little bit of an insight in terms of the conversations that I have with those patients when you make that periodontal disease referral, what treatments we talk about, those treatment modalities, and how those modalities are going to best serve your patients. So, tonight, what we were going to talk about are NDA lasers, the turbocharged procedures that we use that lead to happier patients and more predictable results. So, thank you for joining in for the lecture. Sit back, relax, and let's move forward with tonight's conversation. So, just a little bit more about myself for those of you who don't know who I am. I'm Dr. Andrew Peterson, born and raised in Billings, Montana. I did my undergraduate at Carroll College in Helena, which is the state capital, sits right at the foothills of the Rocky Mountains. I then migrated westward to Portland, where I finished my dental training in 2013 and then continued on to residency and finished that in 2017. There was a year in between where I did some general dentistry for 1 year in private practice. Further academic accolades that are included here are I became board certified in 2019. Then I pursued my implant interest and really challenged a couple of these implant board organizations. In 2024, I became a diplomat in the International Congress of Oral Implantologists. I became a LANAP certified instructor for the Institute for Advanced Laser Dentistry. I really enjoy teaching in what I do, right? So this really challenged my understanding of the LANAP protocol, which we're going to talk about tonight. And how do I use language to teach other practitioners how to implement these procedures in their office? That was really big for me, and understanding how people learn. Furthermore, last year I became a diplomate in the American Board of Oral Implantology and Implant Dentistry. And this year I will be receiving the fellowship in the American Academy of Implant Dentistry in 2026 in Nashville, Tennessee. So, for those of you who don't know where we're in Arcadia, California. About 20 miles east of Pasadena, sits right in the San Gabriel Valley. So here's my office. We're located off of Huntington Drive, right across from the Methodist Hospital. And here's a few of the operatories, right, that look out to the base of the mountains. So this is my view every day for myself and for my patients. I just want to give you an insight in terms of what the office looks like if you haven't been to our office, or just to give you an idea for your patients what the office will look like. Like I'm really big into patient education. So what I have gone ahead and done is I have created a patient education book. What you can do is you can access that from the website. If you click on the link, it'll give you a printable PDF document that you can have in the office. If you want a hard copy of the patient education book, call my office at 626-447-0945, and I will mail you out a hard copy of this book as well. You'll see some of those cases in this book that we'll talk about tonight as well. So it's a good educational tool to have chairside to run your patients through a bunch of different periodontal procedures. Tonight's topic, like we had talked about, is LANAP. However, there's things from soft tissue grafting, implant placement, sinus grafting, bone grafting, sedation options, right? Just a tool to help better educate your patients and educate yourself as well. So, kind of three main learning objectives that we want to talk about for tonight that I really want you to walk home with a better understanding of the lasers in dentistry, the lasers that are used, the different types of lasers, and why certain lasers are done for different procedures. And it all depends on the wavelength of light. I want you to be able to identify the NDA laser that I use in my office and the variety of procedures that I can do with this laser. The more you know and the more you understand, the better you can educate your patients before they come over and see us at the office. Um, so let's talk about LANAP, laser assisted new attachment procedure. My LANAP journey began in 2019 when I met Dr. Fuentes. I began my LANAP training, I believe, in July of 2019, and I have been doing it since then. Dr. Fuentes was able to mentor me along the way, so it was great to have him as a professional mentor and partner over these past years. So I really want to talk about wavelengths and wavelengths of light on the electromagnetic spectrum. So visible light, as you can see from the slideshow, is about 400 to 700 nanometers. The laser technology that we use is at 1064, or basically we're in the infrared spectrum of light. As you can see on the linear line, NDA lasers, it's at 1064. Your diode lasers are going to sit at about 810 to 980, right? We'll talk about the difference in diodes versus the Periolase MVP7 and what's the main difference in terms of why this laser is so much different than a simple diode. Other lasers that are used in dentistry are going to be your erbium lasers, right around 3,000 nanometers. And then we have our CO2 lasers. So that's at about 10,600 nanometers. So just a variety of lasers, and they're named after their active medium, right, at which the light passes through. Um, so that's just how these different lasers are named. So it's important to talk about periodontal disease and periodontal disease progression. So I have these x-rays up to walk you through the conversation that I have with my patients. And I have these x-rays chairside with the patients, and I'm discussing this process as I'm looking at the patients themselves chairside. So I tell them it all starts with plaque accumulation along the teeth, right? And if we aren't cleaning well or have difficulty removing that plaque will eventually harden and mineralize and turn into calculus. As a good analogy, I tell the patients this is more like a rock in your shoe. It's a local irritant. How do the gums respond to that rock? They become inflamed. They may start to bleed a little bit. The tissues may become boggy in nature. Well, as all of these local factors are changing, also too is going to be the bacterial content. We're going to go from our everyday normal bacterial load to a higher percentage of gram-negative pathogenic bacteria. That's a shift in the bacterial change because the environment has changed because of the buildup of the plaque and calculus accumulated underneath the gum line. So this is just a really good x-ray that highlights a large amount of subgingival calculus that has built up. You can see the rock or boulder formations, as I'll call them, almost like barnacles, right? Growing off of these teeth underneath the gum line. This is a case where the periodontal disease is advanced and the plaque and calculus accumulation was very heavy and tenacious and difficult to remove. But this just highlights the periodontal disease process. As those bacteria accumulate, the bacterial metabolisms and the bacterial byproducts from the metabolism will break down bone and tissue. So that is the overall disease process. So what do we want to do? We want to remove the barnacles of calculus, remove that subgingival calculus, and we want to remove the bacteria. So how are we going to do that, and how are we going to do it with a laser? Well, let's dive in a little bit more. Interestingly enough, the pathogenic bacteria that build up subgingivally with the calculus accumulation have pigmentation to them. So, looking at these vials as you move from left to right, the concentration becomes more concentrated. notice how the pigmentation increases. Very important to make note of the pigmentation because light energy does work where that light energy is absorbed. So looking at this chart, right, you see 10 to the 0 kind of right at the middle of the chart. So anything below that 10 to the 0, there's no absorption. 10 to the 0 and above, there is absorption, right? Absorption coefficients. Now, as we move from left to right, what's going to happen is you notice the wavelengths of light. So you notice at 1064, that relates to the 1 on this chart. Notice as you move up the 1 on the y-axis, notice what is where that light energy is absorbed. It's absorbed into hemoglobin and melanin. It's absorbed into pigmentation. What's pigmented? That high percentage of the pathogenic bacteria also has pigmentation to that. That infected and inflamed tissue that's concentrated with that pathogenic bacteria also has pigmentation to it. So, what does that mean? It means that the laser light energy selectively removes all of the infected and inflamed tissue and it leaves behind all of the healthy tissue. What does that mean for your patient? It means a quicker recovery compared to traditional techniques. So, the other lasers that we'll talk about briefly here are going to be your erbium and your CO2 lasers. Those are water-loving lasers. So, the light energy is only absorbed into water. So, now that we know a little bit of the difference in terms of absorption characteristics, I want to talk about the depth of penetration of the light energy. So when it comes to ND egg lasers, the light energy penetrates deep beyond the tissues, 4 to 5 millimeters beyond the laser tip itself, which is good when we're treating periodontal disease. So I only need to get to accessible depth on these periodontal pockets. I do not need to get to the bottom of the pocket because the light energy is doing work well beyond the laser tip itself, right? We're getting that bacteria that's deep into the bone, deep into the adjacent tissues. And so remember too, the light energy also has about a 26-degree divergence as the light energy is leaving the laser tip itself. So we're going to eradicate all of that Porphyromonas gingivalis bacteria in the adjacent bone into the dentinal tubules, right? We're going to clean that environment and get a fresh slate to start over with. So the main difference between erbiums and CO2s are erbiums and CO2 lasers are water loving, right? The depth of penetration is very superficial. With NDA lasers, that depth of penetration is deep. Big difference in terms of why we use the NDA laser to target periodontal pathogens and why it works so well to treat periodontal disease. The main difference too is you're like, well, I have a diode laser. Well, yes, but remember too, the way the energy is delivered is it's delivered in power outputs, right? Wattages. So sometimes diode lasers, for the most part, are going to be at a 1.5, a 2 watt laser, and it's a continuous beam of energy. When it comes to the NDA laser, more specifically the Periolase MVP7, my average wattage is going to be 3.6 to 4 watts when we're treating periodontal disease. However, my pulse durations can change. So at a short pulse duration, the peak powers are very high, right? So the amount of energy per pulse, if I'm at 100 microseconds, is the equivalent of 1800 watts per pulse. Those high peak powers is what allows for the selective removal of that pathogenic bacteria and the infected and inflamed tissues. So diodes and the ND-egg perioles MVP7, although similar in their wavelength of light near the infrared spectrum, power outputs and the way the energy delivered is much, much different. So keep that in mind in terms of the difference between diodes and the ND-egg, the perioles MVP7. But furthermore, again, we're talking about depth of penetration with the erbiums and CO2s as compared to ND-egg is going to be very deep. So remember, LANAP is a step-by-step protocol. When I talk about LANAP, I am referring to a full mouth disease protocol treated in one sitting. A good analogy that I like to explain to patients is kind of think of those periodontal pathogens, that bacteria, as termites. We just don't tint the kitchen when the whole house is on fire, right? When it comes to LANAP, to treat the full mouth in one sitting is about 2 to 2.5 hours. The laser will selectively remove all of the infected and inflamed tissue and those pathogenic bacteria. That's the ablation mode seen in figure B. In figure C, we're going to use our piezo ultrasonics. I'm going to remove all of the subgingival calculus. In figure D, it's what we call our blunt dissection and bone biomodification. I'm going to make the bone bleed. Why? Because when I make the bone bleed, I'm going to get the body to release stem cells. Then what I'm going to do is I'm going to do a laser generated blood clot. I'm going to change that pulse duration. Remember how we talked about a short pulse duration, high peak powers? Well, now what I'm going to do is I'm going to change the pulse duration to a longer pulse duration and I will get coagulation, right? So that's how we get the laser generated blood clot that contains the live viable stem cells. And that's going to be done around each and every tooth. Finally, followed by occlusal adjustment, which we'll talk about a little bit more. But periodontal disease and occlusal disharmony, occlusal dysfunction, really play hand in hand in terms of bone loss and periodontal disease progression. And then finally, we sit back, we wait, right? What we're going to do is we're going to wait for 6 months before we reprobe. And typically, we won't take new radiographs until the 1 year mark. And I'll show you a couple figures about why that is here in a little bit. Um, just understand it's a full mouth disease protocol with the follow-up care being at 2 weeks post-treatment. So no brushing for 2 weeks. We don't want to disrupt that blood clot. Why? Because that blood clot is your protective barrier that's allowing that bone to start to regenerate well below the gum line. So no brushing, no flossing. From weeks 2 to 4, light brushing, light flossing, and then after 4 weeks, resuming normal hygiene. The key to long-term success is remember, periodontal disease goes through periods of inactivity and periods of activity, right? So the best way to prevent future disease progression are going to be maintenance intervals. A 3 month maintenance interval indefinitely. We know back from the Michigan studies in the 70s by Ramford, regardless of oral hygiene, as long as these patients are coming in every 3 months, disease progression is unlikely to continue. So think if these patients are actually cleaning well and coming in, right? I'm trying to change the way things happen and change the way things were done in the past so that the disease progression doesn't continue. But remember, once a periodontal disease patient, always a periodontal disease patient. So we need to be very mindful of tracking these patients, tracking their maintenance visits, and keeping them on track long term. So that's kind of my spiel with explaining the LANAP protocol, why it works so well. But again, too, we have to understand that there are local tooth related factors at play, but then there's this hierarchy, right? Because more often than not, when I'm dealing with a periodontal disease patient, there's typically some other underlying systemic issues as well. But it's really important. I like this figure because it goes to show the poor oral hygiene, right, can lead to the gram-negative bacteria. The trauma from occlusion can lead to more pathogenic disease progression. Tooth malposition leads to an inability to clean, poor oral hygiene, which can lead to trauma from occlusion, right? Everything is interrelated. One thing affects another thing when it comes to tooth related factors and disease progression. From the patient's perspective, you're like, it's just a pocket, right? No, it's a very complex disease process where we have to think about, our hygiene, the bite, the tooth malposition, right? And I'm just touching on a few basic items as tooth-related factors. There's a multitude of other factors at play as well, but this just gives you an idea that all of these factors are interrelated at the tooth level. But now we need to think about, on top of the tooth-related factors, we have these other comorbidities, such as diabetes, COPD, sleep apnea, right? But then we have our body's immune system too. How do we respond to the bacteria? Do we under respond? Do we over respond? How is that response in combination if we're sick with diabetes or COPD or sleep apnea? You know, everything is interrelated. And when you think of this diagram, I like to think of it as the systemic factors are the way that our immune system responds is probably the most important factor, followed by we need to get these other comorbidities under control, and that will help with prevention of periodontal disease progression. We need to treat the person as a whole, right? We need to get their primary care providers involved. We need to make sure all of these other etiologies are at play because that will affect the end result. And the laser can affect all of these factors to some degree. So it's important too to talk about prognosis, right? I'm just going to read this slide for you here real quick. Prognosis is the prediction of the probable course, duration, and outcome of the disease based on the general knowledge of that disease and the pathogenesis of the disease in the presence of the known risk factors. It can be further divided or categorized into two different ways. It can be diagnostic, it can be therapeutic, or it can be prosthetic. And then we can look at individual tooth-related factors, or we can look at the overall prognosis of the overall dentition. Just different ways to view prognosis. Now, when it comes to prognosis and looking at tooth-related factors, right, what are we looking at? Are we looking at isolated tooth-related factors such as the remaining bone support, the probe depths, the mobility, the furcation involvement, crown to root ratio, root trunk length, tooth morphology, pulpal involvement, sinus involvement, position and alignment? All of those are tooth-related factors. I don't like to look at teeth that way. It'll get you to start thinking about teeth in terms of removal much quicker than when you think about if I am going to treat the disease, what's the likelihood that the treatment outcome will lead to stability? And remember, stability doesn't mean twos and threes. Stability means I want healthy coral pink tissue without bleeding, that's firm, dense, right? When we don't have bleeding on probing, that's a sign of health. So notice how it doesn't just say 2 and 3 millimeter pockets. It can be a 5 and it can still be healthy as long as it's not bleeding and the tissues are coral pink. The patient's coming in for their maintenance visits and we're maintaining these teeth long term. And if the probe depth went from a 10 to a 5, that's a huge improvement. So when it comes to the way that I look at teeth, I look at those teeth. Can I control for the all the etiologic factors at play? right? Is there no endodontic involvement? Is there endodontic involvement? Do I need to get the endodontist involved, right? Looking at all these other factors in terms of occlusion. Can I control for the bite? Looking at systemic issues. Can I control for are their diabetes under control? Are they on their CPAP? Right? All of these etiologies play a role in leading to periodontal stability. So just a different way that I like to think about prognosis when we're treating periodontal disease. And when it comes to treating periodontal disease, I may treat some very questionable teeth. Why? Because remember, periodontal disease is a quadrant code. So I tell the patients, do you want to give this tooth a chance or do you want to remove it? I go, it may or may not need to be removed. I can't look into the future and tell you. All I know is I can treat that tooth. It's not going to get any worse than it is right now. And let's reassess in 6 months. If that tooth has been there for 50, 60 years, what's another 6 months? As long as I've cleaned out the bacterial infection, I've alleviated the trauma from occlusion, making sure all those etiologies are at play. And that's how sometimes I get these really interesting, fantastic results. So again, another good tool is going to be this periodontal report card. I've gone ahead and filled out the numbers for you here in terms of the Miller-McIntyre periodontal prognosis. It gives you some factors at the bottom that give you numbers to categorize things, right? Furcation, diabetes, probe depths, molar type, smoking, age, and then you get a number at the bottom, right? So for tooth number 30, we got a 7. So then you move over into that other column and you see, okay, a score of a 7. In 15 years, there's an 87% chance that that tooth will still be around. In 30 years, there's a 66% chance that that tooth will still be around. When you move down to 8, right, that's when we move from a good prognosis to a guarded prognosis. So again, I don't want to get into the details here, but this just gives you a tool to measure teeth in terms of will that tooth be around in the future or will it not be? Just a good measuring tool for you to look at teeth in terms of their prognosis and their long-term outcomes. So I want to talk about this case. We just have a few cases and case examples that I wanted to include in today's presentation. So here we are, tooth number 30, localized furcation defect. Through and through, grade 3 furcation. You notice the widened ligament space, so there's the trauma from occlusion. The tooth tested vital, confirmed vital by the endodontist, as I sent out for a endodontic consultation as well. Um, and we did a comprehensive exam on this patient. So she really only had the one tooth periodontal defect. More than likely, not usually the case. So you need to think about what other tooth-related factors are at play here. In her case, she had a cervical enamel projection running deep into the furcation that was also removed at the time of treatment, right? We're removing all these etiologies. So here we are with the laser treatment. So the first pass, right? Removing all of that diseased tissue and using my neighbor's probe to measure deep into the furcation. I want to have an accurate measurement to start with. But really notice on this case that distal lingual cusp and look at the heavy non-working wear facet. So in this case, my instinct tells me, based off of my years of experience, that it was trauma from occlusion in combination with a tooth-related factor, aka that cervical enamel projection, that led to the disease progression. I can't tell you how long it took for that disease progression to occur, but I can tell you it definitely took some time. Here we are at 6 months. Incredible amount of regeneration as we've allowed to control for those etiologic factors at play. When I had the conversation with the patient when she first came in, I said, I don't know if I can save this tooth or not. I really don't. The only way I'm going to know is if we try. And I asked her, do you want to take the time and energy and effort to give this tooth a try, or should we just remove it and place an implant? She wanted to give the tooth a try. So we went forward with the treatment, and here's the result that we got at 6 months. Now remember, I like to follow up these cases as long as possible. So even after 6 months, I wanted to follow up this patient again. So here's the before and after at 6 months, and here we are at 14 months. Incredible result. So she's on a strict 3 month maintenance protocol. And what we're doing now is I see her every 18 months and I will continue to follow up with her. She's about due for her next 18-month follow-up. So it'll be good to see what about 3 years looks like post-treatment for this case. But again, fantastic result, saving the teeth. In my opinion, there's no better tooth replacement than your own natural tooth that is already there. Here's another interesting case. Now, this case was more generalized, but I'm kind of focusing in on the upper left tooth number 15 because this case really highlights, deep grade 2 furcations on the mesial and the distal, a grade 1 buccal furcation on this tooth. Localized severe probe depths, 10, 12 millimeters in length. So again, we went ahead and proceeded with the LANAP protocol. And again, remember, I told you this was a full mouth case. I'm just highlighting it on this one tooth. This prognosis on this tooth was guarded when I first came in. But remember, prognosis is a dynamic process. So here we are, 6 months later. Incredible osseous regeneration and osseous fill on that tooth. Uh, Furcations, grade 1. The bone fill is unbelievable, right? So this tooth is stable. It's moved from a guarded prognosis into a good prognosis. So remember, with treatment, prognosis is a dynamic process that can change. So just another case about how I approach teeth and the conversations that I have with these patients. Another interesting case that came to see me about 3 or 4 years ago now at this point. So, whenever a patient comes in to see us for a comprehensive exam, we're always taking photo documentation. Why? So I can see how the disease is progressing. Maybe we have some recession defects that I want to monitor. Okay, well, we have a snapshot at time 0, and now I can see, okay, the recession is getting worse. Mrs. Jones, it's time to treat you for that recession defect. And two, it goes to show how tissues change over time with laser treatment. So, a full mouth set of x-rays. When it comes to a case like this, if there's mobility, grade 3 mobility, caries with advanced pulpal involvement, I'm going to remove those teeth at the time of LANAP. I can treat teeth with no mobility and severe bone loss. So just highlight, tooth number 14 here. We'll take a look at that in the future. And let's look at tooth number 19 as well. Surprisingly, no endodontic involvement on 14 at this time. So that just gives you an idea of kind of how I think about teeth. Tenacious amount of calculus. The lower incisors have grade 3 mobility, advanced bone loss, horizontal bone loss, almost down to the apical extent of those teeth. So those teeth are going to go as well. But my goal is to try and save as many teeth as I can for this patient. So here we are at the 3 year post-op appointment. We ended up placing 2 implants and did a 4 unit bridge for the patient. But just look at that tissue quality. He's stable. He's healthy. We have good tissue thickness around those implants. Those implants are placed at an appropriate depth and level, and he is coming in like clockwork with his periodontal maintenance appointments. Another FMX to follow up 3 years later. Huge difference in terms of the osseous fill, but I want to highlight two teeth here. So look at tooth number 14 before and 3 years later. Incredible osseous fill here. Tooth number 19, 3 years ago, and tooth number 19 in its present condition. So notice there was a lot of heavy occlusal adjustment for this patient. We had to control for the disease progression and the trauma from occlusion in combination with that high concentration of pathogenic bacteria led to really advanced disease progression. So occlusal trauma needs to really be addressed well with these periodontal disease patients. I think this is one of our one or two more cases just talking about how the laser works in the cases I treat. I highlighted this one because this is one of my longer follow-ups from 2020. Localized vertical defect on the distal of number 7. Here we are. That tooth was splinted because of the mobility, but a 1 year follow-up. And look at that 5 year follow-up. Notice how with one laser treatment, one treatment, bone will continue to improve over time, really up to about 3 years. So, in terms of the healing curve, I'll get about 80% bone remodeling and healing and improved density, 80% in year one, about 15% more improvement in year two, and about 5% in year three. But again, that's why we continue to track these patients long term to show how osseous regeneration occurs over time. Another case here. Um, this young gentleman came in to see me for a furcation involvement on tooth number 14. So when I have cases like this, not only do I take two-dimensional imaging, I also like to take advanced three-dimensional imaging to further see what is the depth of the furcation involvement and what kind of bone am I working with inside of the furcation. As you can see here, the buccal furcation extends all the way to the buccal aspect of the palatal root. There is no bone in between the roots of these teeth is really what I'm trying to say here. Yes, we have some short root trunk lengths, some short root form from previous orthodontics, but for this case, we're only honing in on the periodontal disease and the furcation involvement on tooth number 14. Here we are after LANAP treatment, 6 months. So it's working, right? Things are improving. They aren't perfect, but they are getting better. So here we are at 12 months. And again, a 2 year follow-up on this case. So you can see the initial presentation in the winter of 2024 to the patient was just seen in my office for his 18-month follow-up in March of this year. So notice too how things greatly improve in terms of the bone fill with the three-dimensional imaging as well. I mean, the two-dimensional images says speaks volumes, but wow, what a story that tooth tells me with the three-dimensional imaging. Incredible results. I'm able to save this tooth for this young gentleman. And now, too, what we want to do is we want to talk about some orthodontics and maybe distalizing the roots on number 15 a little bit for better root proximity. Right now, those roots are a little close to one another. So we had a conversation about that, and he's at risk for disease progression continuing interproximally there, right? So these are the conversations you need to have. You need to educate your patients. And this is why I like to take a comprehensive approach to managing these cases. Here's the after photos 2 years later. Great tissue quality, minor tissue shrinkage. We have periodontal stability on tooth number 14 right now. So this tooth went from a hopeless prognosis all the way over to a good prognosis with one treatment. So here we are just talking about the tissue effects and the osseous regeneration. A couple classic studies by Dr. Ray Yuckna and Mark Nevins looked at different intervals, 3 months after treatment, 9 months after treatment. So this just shows that osseous regeneration continues over a longer period of time than one may expect. So that's the key takeaway here is things continue to improve with one treatment. Some other studies done that helped define this logarithmic this inverse logarithmic scale to help with how much bone fill will happen over a certain duration of time. So we've talked about natural teeth, right, with the LANAP protocol. Remember a full mouth disease protocol. If I'm using the Paralase MVP7 at site-specific areas, I call it laser-assisted regeneration. Now, when it comes to we've treated natural teeth. Now I want to talk about LAPIP, laser-assisted periimplantitis protocol. How do we treat alien and failing implants? Well, I can do it with the same laser. The only real difference when it comes to treating natural teeth versus implants is I really need to be mindful about the amount of energy that I am delivering because the titanium acts as a heat sink, right? So natural teeth are much more forgiving. I can give them much more energy as compared to an implant. The amount of energy delivered, if you're comparing a single rooted tooth to a single implant, it's about a third the amount of energy just to give you some perspectives here. But it's the same protocol, right? We take our probe depths, we remove the diseased tissue, we make the bone bleed, do our laser blood clot, and adjust the bite. All very similar to the LANAP protocol that we just talked about. So here's a case that I treated a few years back. Here, initial presentation, we have the circumferential moat-like defect on the implant at number 14. We have the endodontic treated tooth number 15, with a vertical root fracture on 15 as well. So we ended up removing number 15, bone grafting 15, and treating 14 with the LAPIP protocol. So nothing but a laser regenerated blood clot around that existing implant. So here you can see the bone fill at number 15, but you can see the improved density at number 14. So again, this is only 6 months post-treatment, and remember, things will continue to improve. But at 6 months, I already have resistance to probe depths. So we just have to allow Mother Nature to heal and allow that bone density to increase over time, but this bone will continue to fill. So let's talk a little bit about just some value-added procedures. So there's a lot of other procedures that I can do with this laser to treat your patients and provide them a better treatment outcome and a better patient experience. One of the things we like to do is we like to pre-treat our implant surfaces with either a UV light or the laser treatment, right? What that's going to do is that's going to remove all of the hydrocarbons that have built up on the surface of the implant. So it's what we call photo functionalization. A basic implant that comes dry from the manufacturer will have a layer of kind of hydrocarbons built up around that implant surface itself. What does that mean? It means the average bone to implant contact on a non-photo functionalized implant is about 50 to 60%. When we photo functionalize the implant, we treat with the UVC light and or the Periolay's MVP7 laser. What'll happen is it'll remove that layer of hydrocarbons. So now the surface goes from hydrophobic to hydrophilic. So notice how you can see the beading of the saline on the implant. That's a hydrophobic surface. As compared to the photofunctionalized implant on the right, that is a hydrophilic surface, water loving. What does that mean surgically? It really means that we increase our bone to implant contact to about 95 to 98%. And it really reduces the healing curve here in terms of the osseointegration and the reduction in the stability dip. So this is what the BLAST protocol looks like to photo functionalize the implant, removing all the hydrocarbons on the implant surface. Just a quick little video that I took to show you how we treat implant surfaces. prior to implantation. Again, we get a regional acceleratory phenomenon, an accelerated healing response. And as you can see here, if you look at this chart, just go straight to the bottom and notice the healing time, 1.5 months on photo-functionalized implant surfaces. So we can restore these implants faster with better bone to implant contact. More bone to implant contact, in my opinion, will lead to less disease progression because more bone is contacting that implant. A lot of other value added procedures that we can use. I'm not going to go through this list one by one, but just know I can use this laser in a variety of different procedures. That's the key takeaway message here. We can remove pigmentation on gums. Notice the before and the after. We can remove pathology, right? We affect the tissue. We don't resect the tissue. Notice how the area is healed up quite well within 4 to 6 weeks post-treatment on this case. We can do laser-assisted GBR. I can do my hemostasis setting and bone graft simultaneously to get more predictable bone grafting results, whether it's for a socket preservation and or a large ridge augmentation. All good things that can happen that'll lead to better, more predictable results for your patients. The more predictable those results, I believe the happier the patients will be. Laser biostimulation. We do this for every procedure. What is it? It's using the laser in a non-contact mode. Think of it as light ibuprofen, right? That light energy is going to penetrate deep into the tissue. It's going to shut off those pro-inflammatory mediators. What's going to happen? Faster healing with minimal discomfort. Whether it's connective tissue grafting, sinus augmentation, ridge augmentation, implant placement, uh, periodontal disease treatment, crown lengthening. I use it for every single procedure that I do. So this has been a game changer in terms of the healing cascade for our patients. So just a few more cases to close out for today's presentation. Just some interesting ones that kind of hit home to me that are multidisciplinary. So localized tooth number 25, localized recession defects here, lots of pathology. So we treat with LANAP, we splint those teeth, and now we've gotten good bone regeneration. So after we treat the disease, the next thing we want to do is we want to treat that soft tissue, right? So we're going to do a coronally advanced flap, and we're going to laterally close the facial aspect here. We're going to thicken the tissue. We're going to augment it and hopefully make it less likely for disease to progress. So after this treatment, we grafted both buccal and lingual. It would really be nice to level and align these teeth, lingualize those teeth a little bit and get them into a better position because that'll lead to even more stability. And remember, the more stable those teeth, the less likely we are to have the disease progression return. The other thing that we're able to do with LANAP is I'm able to treat more medically complex patients, patients on blood thinners, patients with uncontrolled diabetes, patients on medications that lead to gingival overgrowth, such as anti-seizure medications or heart medications. We get a lot of challenging medically complex cases where we do a medical consult to make sure that they're able to undergo the procedure, but it leads to a safer, more predictable outcome for these patients, right? Because I'm not having to cut away the infected and inflamed tissue. I affect the tissue and I watch it heal. So here's a case, initial presentation on the top, 2 weeks post-treatment for LANAP, 4 weeks post-treatment. So notice that tissue shrinkage and healing. And then here we saw this patient 1 year post-treatment. So a big difference in terms of that gingival overgrowth. It's not perfect at all, but the patient's able to keep those teeth clean and maintain them better. And he was able to keep almost all of those teeth. I think we removed one or two teeth due to some combined endoperio lesions. So, just the way that I'm able to treat and offer these procedures to a variety of patients, not only medically complex patients, we also treat a lot of special needs patients at our office as well. So, just to reiterate, we talked about the NDA laser technology. We explained the differences between the Periolase MVP7 as compared to diodes, those peak powers, right? Which lasers are absorbed in pigmentation versus which ones are absorbed into water. And our water-loving erbium and CO2 lasers are going to be very superficial in terms of their depth of penetration. Furthermore, we've talked about a few different protocols, right? LANAP, the laser around natural teeth, full mouth disease protocol, LAR, laser assisted regeneration around localized site specific areas, LAPIP, treating alien and failing implants. We talked about the BLAST protocol, photofunctionalization, how that improves bone to implant contact. And we talked about a variety of other value added procedures, treating pathology, pigmentation removal, and laser biostimulation. So to highlight those different types of lasers and how they work really well in our office. So this was just an overview of LANAP. They're using the Periolase MVP7 at Arcadia Perio. What that looks like in terms of my conversations with your patients. How do I like to treat the disease? How do I explain disease progression to the patients? I wanted to give you guys a few different case examples of the way that I like to approach these cases in my office. So, thank you for watching today's lecture. I really appreciate you taking some time out of your day, and hopefully, we will see some referrals and I will be communicating with you soon. Thank you so much and have a good day.